Welcome. Thank you for being here this morning. Michelle Joy, President and CEO of Carson Tahoe Health. This is our second employee forum of the year, so our summer employee forum. Lots of familiar faces. Anybody coming to the forum for the first time? Okay, we got a few people. Great. So for those that have been here, it really follows the same agenda that we've done other times. Any questions, rumors, concerns, anything you want to learn about today, hear about, feel free to ask. We'll touch on employee engagement survey, go through Q1 review, and then talk a little bit about value-based care, and then end with our strategic plan update. So with that, any questions, rumors out there that you've been wondering about? Joe? Nothing? Okay, I know you'll ask if there's anything. All right, well, we will jump right in then. So employee survey. Who has seen department employee engagement survey results? Yeah, okay, great. Who's seen overall organizational results? Okay, a little bit smaller group. So we'll go through the organizational results. We took the survey in January, had a response rate of 64.3%, lower than last year where we came in at 70.1%, but definitely higher than where we see the benchmark across hospitals and health systems, similar to Carson Tahoe, which was at 45%. So continue strong response rate, which is great because when we look at the results, then it really is a better reflection of how everybody in the organization feels that things are going. When we look at employee engagement, our overall engagement score was 74% on this year's survey, compared to last year's survey where we were at 66%. So continued improvement from an overall engagement perspective. The way that Energage looks at that, which is our survey company, there's 4 key questions that drive that overall engagement score, which is really consider searching for a job at another organization. Top one is how we did in the survey. Bar below it is the benchmark with other hospitals and health systems across the country. So on that one, we were 10 percentage points higher. I would highly recommend working at Carson Tahoe Health to others. I'm satisfied with my job. Carson Tahoe motivates me to give my very best at work. So those 4 questions drive that engagement piece. And where it says no data for last year on the far right, that's because we did not have those questions in the survey last year. When we talk about workplace experience, it is a separate score that looks at engagement, alignment, empowered to execute, feeling respected and supported, enabled to grow, and then fairly valued. And on that one, we ended up with a 70% positive score across the organization from a workplace experience, 4 percentage points above where we ended last year, and also 3 points above the benchmark nationally. When we look at specific questions within the survey, we look at which areas did we have the biggest increases, which areas did we have the lowest or the highest decreases year over year. So these are the ones where we saw the biggest increases around growth, direction of the organization, and then operating by strong values. What we also saw this past year is that none of the questions decreased from the prior year. So that's pretty amazing. I don't think I've seen that happen in all the years that we've been taking this survey. Next one talks about comparisons to the benchmark. So how are we doing compared to other similar organizations out there in healthcare? Again, that commitment piece is one of our higher statements relative to the benchmarks, same as pay, as well as work-life balance. The areas where we were just only 1 point below the benchmark, so really close, not like 20 points off the benchmark. Directors understand what's really happening. Open-mindedness, encourage different points of view, and then work stress is manageable. Any questions on any of those results? Anyone surprised by those results? Okay. So overall, lower participation, we talked about that. Increased favorable responses in every statement year over year. Few departments to celebrate that had the biggest improvement across the organization. So Carson primary care on the medical group side, respiratory therapy, as well as the medical group admin and support area. We'll talk a little bit about reasons people love their job at CTH, and then our focus areas that were identified where we have the greatest opportunity for improvement by department is peri-op specific to OR, endo, and central processing, monitor techs, medical records, and then our BHS service lines. So when we talk about this, these areas have spent a little bit more time working on their action plans and identifying exactly what it is that they're going to be working on. So the other part with the survey, as you know, for those that have taken it, is there are multiple questions where folks can provide comments. And if you provide a comment on one question, then it fires off another question and another question. And then sometimes you just get to the point where it's like, I'm not answering any more of these questions. But we ended up with over probably 3,200 comments on the survey. All of those comments have been read by the senior leadership team, by multiple folks within HR. And then out of those comments, it creates word clouds. So the first word cloud is, how do employees describe the culture? Bigger the word, bolder the word, the more times it was used in those comments. And so you can see community, helpful, supportive, collaborative. We also have opportunities, there's negative comments that come through as well around micromanaged, toxic, selfish. So, but overwhelmingly positive responses regarding the culture. And then when we ask, I love my job because, community shows up again, leadership shows up. I will say this is probably the first time that leadership has been in the center of this. Usually it's my coworkers, the people I work with, the people in my department, patients. So a little bit different responses this year from a comment perspective, but we still have supported, appreciate, feel valued, grateful, heard. So again, really positive on why do people love their job at Carson Tahoe. Any questions on any of that? And really, when it comes down to it, it's everybody in this room, it's every employee within the organization driving the culture that we experience, that our patients experience. And then based on our survey results, I've shared these in the past. Everything this time is summarized into one slide. I've not updated this yet, but for Nevada Top Workplace, we were also recognized in 2026 this year based on these most recent survey results. So all of these awards and recognitions comparing us to other workplaces from a healthcare perspective across the country are based on the employee engagement survey results. We have also been taking the same survey since 2022, 2023. We've had it for several years, and so you can see in the past we did not receive any recognition, and so there's been consistent improvement from that workplace culture and engagement. So we asked every leader to share their department score results on the survey, talk about action planning. What does the department want to stop doing, start doing, and continue doing? Any last questions on employee engagement? So Francisco's question is all the awards that we've received, if they get communicated out to patients in the community. So with marketing, yes, when we can, wherever we can, Alexis does an awesome job with all of our social media. And so we have used it on the billboard. Alexis has highlighted a number of those through social media, and then there's other communication that goes out through marketing in the foundation. Any presentations that Kitty McKay and I have been doing in the community all highlight that same slide, which is the last one I did out in the community. I actually had a community leader come up afterwards and ask to spend some time in the organization to understand what we've done to change that culture and improve the workplace, because he is struggling currently within his organization on both the leadership piece as well as just overall engagement in the organization. So, yeah, and then I think as we also do all of our recruiting and hiring events and everything, this information gets shared as well, because that's a huge piece on attracting new employees. So Q1, like we always do, just touch base briefly on projects that got completed in Q1. Big one that was an initiative for the latter part of 2025 going into 2026 was replacing PACS. So PACS is the storage system for imaging, images and reports. We went from Change to Sectra, so that's been a huge transition that took us a lot of time. When you look at that list, it is all replacement. Buildings, 20 plus years old, medical gas panels need to be replaced, doors need to be replaced, ER exam lights as well, and then just a couple other pieces, speech therapy, new video swallow chair, lab got a new centrifuge, and then Minden Primary Care Clinic had their flooring replaced. If anybody had been in that space, it was pretty bad. It probably was 25, 30-year-old flooring. So it was great to be able to get that replaced as well. Q1 tends to be a little bit lighter list, just because it is the start of the year. We're wrapping up a lot of things from the end of the year, trying to just see how the year is starting before spending a lot of dollars. Community benefit, so like to share just the number of active volunteers that we have. This continues to increase. We're at 124. I think at the end of the year, we were at about 118 volunteers. So they continue to recruit and bring in more volunteers, which is great for the organization. Not going to go through all the detail on this slide, but did add to this slide actual impact, like how many people we had, 159 total HeartSmart screenings that were done across 3 days. So identifying how many people did we touch when we support or attend these various events. The other piece is the foundation put some information together for this quarter as well. So in Q1, we had 606 employee donors. Pretty amazing, because historically in the organization, we were between 200 and 300 on a regular basis. And so the number of employee donors continues to increase. And it's important that if you're an employee donor, you know where those dollars are going and where we're making investments. And so the foundation, just in Q1 alone, provided over $142,000 for equipment, patient care, program support, and then they also funded 16 advanced certification scholarships for our employees. And so that's available for employees that are looking to get further certification, and the foundation has funds available to be able to support that. They also new washer and dryer over at BHS, so staff were really excited about that. I had infection prevention in here yesterday, she was excited to have new washer and dryer. It's the little things that make a big difference. All right, Q1 financial performance. So when we look at volumes, so inpatient discharges for Q1, we're below budget, below prior year. Same thing with surgical cases. One thing that, if you remember from prior conversations around inpatient admissions, we have seen a decrease if you look at prior year. So inpatient admissions, or discharges, about 3,000. Dropped a little bit in Q2, dropped again in Q3, and has stayed essentially Q3, Q4, Q1 at that same level. Anybody know what's happening when we talk about inpatient discharges and why for the last 3 quarters we'd see that decrease compared to the first 2 quarters of last year? And we don't have a slide for it, but we are going to add a slide for next time. What started happening in Q3 is patient comes into the ER, has to be admitted. If they're Medicare Advantage, which majority of our patients are Medicare, either Medicare fee-for-service, traditional, or Medicare Advantage plan, an authorization has to go, a prior auth has to go into that Medicare Advantage plan company, and they are denying the inpatient admit request. And so those patients are sitting in observation status. They're still getting taken care of. If you're on the units, you know you don't really take care of a patient any different if they're an observation patient versus an inpatient. And so the insurance companies are denying the inpatient admits. And so folks have to stay in that observation status. Impacts us because there's a big difference in what we get reimbursed for an inpatient versus an observation patient. Doesn't cost us any less to take care of that observation patient. And then as the patient, because observation is considered outpatient, they have a greater financial responsibility on that bill. And it is not just happening to us. So end of last year, I met the chief operating officer at a conference for Peace Health, which is a system based in Washington. They're in Oregon, Alaska. We brought our case management team, our CNO, together with several of his hospital CNOs as well as his case management team to talk about this issue, because Q3 last year, they saw the exact same thing happen in their organization. So this is something that is happening across the board. It is not just happening here in our market. Everybody is struggling with this inpatient versus observation mix. Does that make sense? Okay. Any questions on that? Okay. Next slide just shows ER urgent care visits, so slightly below where we were last year in Q1. Definitely not the ER. It is on the urgent care side that the volumes are lower. The ER, as many of you know, is super, super busy. When the ER folks were here on Monday, the patients are also sicker that are coming in. And that's typically what you see happen when there's a lot of pressure on folks, whether it's gas prices, grocery prices, utilities increasing. Folks will pay all of their other bills before seeking health care. And by the time they're have to get health care, they're condition has worsened and they end up in the ER seeking services. And so we're definitely seeing that. Typically we'll see 2 to 3% increase on ER volumes compared to prior year. For June alone, we're seeing probably projected we'll hit a 10% increase compared to prior year just for this month. So it's happening like we typically do in those tough economy years. This slide just talks about the medical group. In the past, we either present medical group visits or we present worked RVUs. This time we're presenting them side by side. So you can see compared to prior year, our worked RVUs are pretty flat. Visits are actually down. And the reason that you see that, what that is telling us is worked RVU is essentially complexity of the patient that's coming into the clinic, so similar to acuity on the hospital side. If you have a new patient visit, that's a higher worked RVU. If they have a lot of chronic disease, comorbidities, that increases oftentimes that worked RVU. Procedures increase that worked RVU. And so, yes, we saw less patients, but we saw higher complexity or more new patients in this Q1. Documentation also makes a difference on that worked RVU, as well, as somebody pointed out yesterday. But that's why we typically look at worked RVUs versus visit, because it gives us a better overall picture of what's happening in the clinic. So net operating income. We budgeted in the year to be pretty flat. We ended up, so break even, we ended up just above break even for Q1. I'm going to show you our scorecard slide that actually is current as of the end of May. So it is going to not look this positive when I show you that scorecard. And then yesterday we got the question, why is Q3 budget so high? That is tied to a lot of one-time expenses that we knew we would have in Q1 and Q2. And so when those expenses aren't recurring and they don't hit in Q3, then your budget target is going to go up if you're expecting your expenses to be less. Any questions on this? Okay. We always share as well days cash on hand. So ended the year just under 180 days, sitting for Q1 just above 180 days, probably about 188 days. I will preface again, when we look at the scorecard, it's going to look a little bit different year to date, and I'll explain why. And then AR days. So AR days is essentially all those bills sitting out there. We've provided all the care, insurance company has paid. Usually, some of it is made up of what patients owe us, and then another part of the AR days is what the insurance companies have not paid us yet either. And so you typically see Q1 a little bit higher starting out the year, just because the insurance companies don't like to pay us at the beginning of the year. Actually, any time of the year, but it's worse at the beginning of the year. And it's getting harder and harder to collect those dollars. So again, we get denied on more of the claims that we submit to the insurance companies. And you can see that just year over year, that continued increase in accounts receivable days sitting out there. Okay, any questions on volumes, that financial piece, where we're sitting? Okay, so scorecard-wise, we'll start at the top. Employee engagement, so recruitment, retention, vacancy rate. Yes, we're red on first-year turnover, total turnover. We are not that far below what the national averages are. We had somebody in here on Monday that is from the East Coast, and she's like, those facilities would love to see those numbers from a turnover perspective because they are significantly higher. And so yes, we're red, but not that far off of national averages. The other piece is we do exit interviews if employees want to do an exit interview. So anybody that gives their notice, resigns, is asked if they want to do an exit interview. So we do collect that information. And the other part is we have been seeing a lot of folks leaving due to family or relocating out of the area, which really is out of our control when you talk about that turnover piece. Vacancy rate, which is a new measure for us on the scorecard, is really looking at how many open positions do we have in the organization compared to the number of positions that we actually need to have filled to take care of patients and the community. And so our vacancy rate year to date, so through May, is actually 6.6%, which is really good. We have run vacancy rates in the past as high as 10, 11%. So great job by the recruiters, by the leaders, by getting folks onboarded, coming into the organization. Next section is patient experience. So continued improvement happening across the organization when we look at patient experience. These numbers don't match because year to date is actually our scores as of the beginning of the week on Monday. These two areas in red, communication with doctors, communication about medicines. Q2, we've seen improvement from Q1, as you can see by that year to date score going up as well. And then really the highlight of this whole slide is this section under quality. And this is really what we're all about, patient care. And it gets measured through these two buckets, but this one is the outcome piece. So we've had 0 post-op respiratory failure fallouts for Q1, same with post-op sepsis, CAUTI. We did have a couple CAUTIs in Q2, but to have none in a quarter, like I've not seen the quality section look this good on the scorecard probably the entire time I've been here. So this is a huge shout out to the entire team on what we're doing to prevent infections and hospital-acquired conditions. CLABSI, MRSA, so 0, and SSI, surgical site infection, colon surgery, we had 0 as well in Q1. So really impressive work by the entire team on that. And then the last one on here is hand hygiene. So we added hand hygiene to the scorecard this year. If folks saw our Leapfrog score and all the media around Leapfrog scores this year, we came in at a C. I will tell you that if we would have had hand hygiene on our scorecard last year, we would have been a B. Not that we were hitting our target, just the fact that it was on our scorecard and it was recognized across the organization as something that we were working on, even though we were still working on it because it wasn't on our scorecard. So Leapfrog has not only some quality outcome pieces, there's a number of sort of administrative measures that they factor in. And so if everything else stays the same, we will be back to a B on that one. Readmissions, we are red on readmissions, but again, this is another one where if you look at nationally, most organizations are closer to 15% on a readmission rate. So we continue to perform well on readmissions. It's just that we have set a more aggressive target given where we've been in the past. Mortality, improvement happening in mortality for Q1, higher than where we were at the end of 2025. We ran an inpatient hospice program for part of 2025. So if a patient qualifies for inpatient hospice, while they're a patient here, they get rolled into inpatient hospice, they are no longer a patient of Carson Tahoe. If you look at our patient demographic, we have a lot of folks that are here on comfort care. And even though they're identified as comfort care, they hit our mortality rate scores for us. So the inpatient hospice piece helps adjust that a little bit. Any questions on any of that? Jackie?
With insurance companies now allowing them to go inpatient and still in observation status, would that change our readmission rate, or do the observation patients still go into our readmission?
So do our observation patients hit our readmission rate? I would say that no, they do not, but I'm going to look to quality to really, or Donnie Burt, to answer that question. I would say no, they don't, because it really truly is. If you, if it's an inpatient, like if you are discharged from inpatient, the measure is coming back to any facility for any cause within 30 days on that measure. So observation would not hit that piece. Where they would hit is potentially if they had an inpatient admission and then ended up back here within that 30 days. What I don't know is if you have to have another inpatient admission on the back end of that. So great question. We'll clarify it in the FAQ when we send that out. Yeah. I'm saying that they don't fall into that. So, yeah. What other questions? Okay, let's talk about the financial piece. So, days cash on hand ended Q1 at 188 days cash on hand. Year to date, we're sitting at 229. So again, days cash on hand is that we can operate the organization without receiving one single penny of income coming in. So to cover all of payroll, all of our supply expenses, lease payments, utility payments, every expense that we have enough funds to operate for 229 days. There are organizations, hospitals in this country that are at 60 days cash on hand, 70 days cash on hand, which is really scary to me. So we're sitting in a good spot from a cash perspective. The reason that we have jumped so much from 177 to 229, somebody yesterday guessed that it was stock market performance. Can't say that the market's been that great. I mean, it's been good, but I don't think my stocks went up that much in just 5 months. But what it is Nevada implemented a provider tax, a hospital provider tax 3 years ago. And so the way that works is based on your Medicaid volumes, the state projects what your volume is going to be for the year that the provider tax is in effect. They model that out and they say, okay, great. Hospital A, Hospital B, Hospital C, Carson Tahoe, here's what the tax is that you have to pay to the state. The state then gets additional money from the federal government for the Medicaid program because they've collected a tax from the hospital. There has to be some net losers on paying the tax and then what you get back from the state in your Medicaid payments. The state tries to minimize who those net loser hospitals are. So essentially, majority, almost everybody except for, 2 or 3 hospitals are picking up on that Medicaid payment by paying that tax. First year, our model was $2 million net that we were going to get. Second year, we were $5 million net. Third year, we were $45 million. So we have been paying our tax for this year. Based on the model, they are paying us back on the provider fee 45 million divided by 4 quarters, whatever that comes to. That is what is driving our days cash on hand, because we're getting that payment and we're putting it in the bank. The other part of that program, and the reason that we're putting it in the bank and we're not recognizing it as income from a net operating income perspective, is because the state can come back and say, oh, through a reconciliation process 3 years later, that your Medicaid volumes weren't what we projected them to be, so your actuals are less and you need to pay money back to the state. And so we don't want to get in a situation where we have recognized that money as income and then have to pay it back in 3 years. So we're just leaving it sit in the bank account until our auditors potentially may come in and say, well, you have to recognize some of it. But right now we're not recognizing any of it, if that makes sense. So that's why when you look at this, days cash on hand is great, but our net operating income, we are sitting right now through May at a $7.6 million loss. We had a couple of one-time hits in April and May, but I will tell you what is really driving this is that conversation we had about inpatient versus observation. It's really starting to catch up with us. And so lot of work being done to really understand, is there anything else that we can do on that inpatient versus observation piece? Are we leaving dollars on the table anywhere else? Really looking at all of our payer contracts, because we're already operating lean. Productivity is great when we look at productivity. We've talked about that in the past as well. Folks flex when the volumes aren't there. That's exactly what we need to be doing. And so it's a lot of external factors that are impacting that current performance for us. And again, almost 50% of hospitals around the country are operating in the red like that. So it's a challenge everywhere, and everyone's working on the exact same thing. Any questions on any of that? Okay. So on a positive note, though, it is a great Q1. Absolutely. When you look at those quality outcomes, I mean, that is what it is all about, is that patient care and those outcomes that we're experiencing. All right, value-based care. Have you guys heard about value-based care, those terms before? It's coming fast. Lots of changes happening from a healthcare perspective. Everybody, I'm sure, hears about how unaffordable healthcare is. It continues to get more and more expensive. Everybody's feeling it on the healthcare side. And so traditionally, we have been paid based on volumes. We had fee-for-service contracts. Our payer contracts back in the day, back in the good old days, I don't know, in the 80s, early 90s, even for some places, especially out west, into the 2000s, we got paid percentage of charge. So whatever we charged a patient, the payer contract would pay us 75% of that charge. And every year you could increase that charge and your contract stayed the same and the payer paid you 75% of what that charge was. Then things started to change, more and more focus on what's the actual outcome. We're not going to just pay for volume anymore. And so now the contracts are written that you get basically percentage of Medicare as your payment. And so you have to figure out how to manage that cost. Now, more and more is tied to, we're going to pay you for what your outcomes are. we've talked about this before from a value-based care perspective. Everything in that quality section is part of pay for performance from a Medicare perspective. So what are your outcomes? How do you compare to other hospitals across the country? What's been your rate of improvement? That has driven incentives on our reimbursement from Medicare. So as we move into value-based care, for those that were in therapy before, a number of years ago, it was mandatory that we participate in a shared savings program around total joints. And so Medicare came in and said, for any total joint hospital, you're responsible from pre to 30 days post joint replacement. Any expense within that is bared by the hospital. We participated in that. We ended up with some savings based on what our past performance was, shared it with the orthopedic surgeons. No longer mandatory, so we quit doing that. CMS, which is Medicare and Medicaid, they have CJR plus now on the docket to say, okay, we're going to make CJR mandatory again. And guess what, hospital? You're going to be responsible for either 60 to 90 days post that discharge. So everyone, especially the federal government, is trying to find ways to reduce what they have to pay for the care that's being provided. So under value-based care, it's about outcomes. It's about preventing hospitalizations. It's about preventing ER visits, because that's where all your high-cost dollars are. What are we doing to ensure that the community has access to care in the community? And we're really focused on keeping them out of the hospital. It's not anymore going to be about growing the volume in the organization. It's going to be about keeping people healthy and keeping them out of the hospital. So payers are moving to this. Kaiser's coming into the market. They are that really traditional managed care, stay within network, stay on the outpatient side, do not get hospitalized. And we entered into, effective May 1st, with our Medicare Advantage plan with Prominence, a full risk contract on the hospital side. So we have never done this before. And what essentially that means is for those Prominence Medicare Advantage plan members, if they come into the hospital, we still submit a claim, but we get paid one lump sum every single month by Prominence, regardless of the number of patients that we take care of. So that means that if all these Prominence patients come in, they're seen in the ER, and they all get admitted, and we're double those number of Prominence patients than we were, say, a year ago, we don't get any additional payment. So we have to figure out, how are we keeping folks out of the hospital? It really, truly is from a value-based care perspective. How do we have access in the clinics, both primary care and specialty care? How, when they come into the ER, do they truly have to be observation or admitted? Can we get them in to cardiology the next day to be seen? Are they getting their meds when they need them? Oftentimes on those readmissions, it is somebody comes into the ER, they then try to go to the pharmacy. Pharmacy's either closed, pharmacy doesn't have the med that was ordered by the ER doc, and so they just go without. Then they end up back in the ER. And so making sure that we have everything coordinated from a care perspective so that we can make sure that it's the right thing to do for patients. I don't want to be in the ER. I don't want to be in the hospital. So what are we doing from a community perspective to ensure that folks are getting access to the care that they need so that they don't end up in the ER? Does that make sense? Anyone want to guess how many lives? So when we talk about Prominence Medicare Advantage, Prominence looks at their members on that plan, those that live in Washoe County, so urban. Then they look at their rurals. Their rural is Carson City, Douglas County, and Lyon. So that rural piece, which is what we're responsible for under this contract, anyone want to take a guess at how many lives we're now responsible for essentially on the hospital side? No. It's about 12,000. And of that 12,000, roughly 2,300, 2,800 are currently being seen by one of our physicians. So that means 75% of those folks are not, we don't have really good access to them right now. But if they end up in our ER, we're responsible for that cost of care. And so the other part is length of stay. This is where, from a therapy perspective, there's a direct impact, length of stay wise, because if we look at and a patient's expected to be here for 3 days, their geometric mean length of stay, which CMS puts out, here's what that mean length of stay is based on all the historical data for this diagnosis. If that patient ends up being here for 5 days because therapy wasn't available, because we couldn't get their med for them, because we couldn't find placement for them, at discharge, we don't get paid anymore for those additional 2 days. And so all of that factors into performance under value-based care as well. So it is a huge shift on how we have been paid in the past, as well as how we have approached taking care of the community and taking care of our patients. A little stressful because it went into effect May 1st. We had 6 weeks to make that transition. We explained all of this to the board because there is a risk component to this. There's also an upside component to this because if we have greater savings than what Prominence is currently paying us month to month, we actually share in savings within this contract as well. So there's an upside to the contract. But if we can't manage these patients, and it costs us twice as much as what we just got paid for the month, that $7.6 million is going to look really bad really fast. The alternative, if we didn't agree to do this, was Prominence was going to give notice to those 12,000 individuals in our community, which would have given them 90 days to change to another Medicare Advantage plan, which is unfair to those individuals. Morally, for us, it was unfair to those individuals to have to scramble and find a new health insurance plan within 90 days. And so we said, we will agree to this. It's coming. We're going to have to figure it out anyways. Let's start with this population instead of starting with 5 times the number of covered lives. Let's start with this 12,000 and really figure out how do we do this, because it's coming from the other payers too. And if we can figure out how to do this and show this to other payers, it gives us leverage in those contract negotiations as well. And those payers are going to want to contract with us because we're driving down the overall cost of care for the community. So complex, but absolutely the right thing to do for our community. Jackie. Yeah, so what else are we doing besides retail pharmacy as it relates to value-based care? We have Press Ganey does discharge phone calls. We have a transitional care management team within the clinic also doing calls at discharge, making sure a lot of it comes down to physician access, primary care access to be able to get them in and seen. So Ryan's done, there's been a lot of recruitment for primary care physicians as well, because if we can get them in to primary care, that physician or provider can be managing that patient's care. The other part that we have an opportunity on, which fortunately, most likely and hopefully during this next legislative session, there's a bill that is being proposed to give paramedics, EMTs in the field more scope of practice to be able to treat in place in the field. And so that would help as well, because we know there are high utilizers of the ER. The ambulance gets called frequently, and so if there's ways that we can, again, partner and manage that in the community, the better that's going to be. And Prominence wants this to be successful. They don't want to leave these markets. And so like Ryan said, they are working closely with us, because if Prominence can be successful in this market, then they want to be able to take it other places as well. And on Ryan's point, a lot of it too is the ER physicians and the hospitalists and partnering with them, because the ER physician has to be comfortable with, okay, I'm discharging this patient knowing that they're going to get seen by the specialist next day, whereas in the past, they probably would have had them as observation or inpatient. So a lot of work being done with both of those physician groups as well. So yeah, more to come. Okay, any other questions on that piece of it? All right, we are at 8:30, but I just want to touch on a few things. So, strategic plan, most of you have seen this before. We've talked about it before. I want to highlight, we have been talking about for several years setting up a family practice residency program here in Carson City. Ryan just received notification Friday off of a grant application that we submitted to the state based on funding that the state made available in the last legislative session to expand GME, because there is a huge physician shortage in Nevada. We got $2.7 million to be able to set up a family practice residency program. We are doing this in partnership with Nevada Health Centers. So there is a lot of work that we need to get done between now and November in order to submit our application into the the ACGME, which is the accrediting body for residency programs in the country. So a lot more to come on that. Our goal is to have our first residency class in the fall of 2028, 5 residents per year, so 3-year program, total of 15 residents after 3 years when it's fully up and operational. So lots more to come on that. That will have a huge impact from an access perspective for the community, because 60 to 70% of residents stay where they trained. And so it's huge to have the state recognize that Carson Tahoe can do what we said we're going to do on this and make that investment. Other part we've touched on it, retail pharmacy. You can see it under construction if you walk down the Sawtooth. So that's happening ideally Q3, but we already have the company that we're contracting with is called Vital One. We already have individuals from Vital One within the physician clinics to help those providers with the medication management piece of things as well, which is great for a patient care perspective also. Community health needs assessment, we've talked about that in the past. We met all the IRS requirements. It's posted on our website. Foundation is doing a lot of work out in the community. And then Sierra Health Collaborative, we continue to do a lot of work on that as well. So I'm only 3 minutes over today. Any last questions, comments? Anything this morning?
Thank you.
Okay, thank you very much. Hopeful that was helpful.